So we are going to start the hip workshop. I invite Dr. Teplenki and his team and Professor R.A. Agrawal, please.
Thank you so much, everyone, for joining us for the HTO workshop. I know this has been a lot, but it's still the tip of the iceberg. We will be having HTO 360 for a dedicated course on HTO at the end of the year, so November 30 and 1st December. So this is an invite to everyone. So I'll just take 1 minute of your time, not much. Thank you. So I know that we learned a lot, but there's a lot to dive into this. So we had this course which was dedicated to HTO. We had a good national and international faculty. Dr. Teramoto, Professor Teramoto, who is the originator of the TCVO technique, was over. And we had the international and national faculty teaching hands-on with the workshop and patient cases as well at the course. And we had great response from the people, and there was a lot of question and answers and doubts that were solved. So we thank you all for your great response for the course last year, the second edition. The third edition will be from the 30th of November to the 1st of December, and we all invite you for the same. I thank Dr. Rajat Agarwal and the entire team of Asamicon to 2024. Over to you, sir.
Thank you.
Hey, podium on, sir. This one is working. Hello. One.
This one? Hello. No. Dear friends, my dear colleagues and friends, now this gentleman, Professor Mikhail Pavlovich Toplinki, he is only one man in the world who is working with the hip dysplasia of the children in Kurgan Center. Now he is going to talk on surgical correction of acetabular dysplasia. You will see the DDH, how he is correcting by Elizarov technique.
Good afternoon. I hope you understand Dr. Barry's joke. According to literature data, over 70% of coxarthrosis cases have a dysplastic nature, and half of these cases associated with acetabular deficiency. Shape and space orientation disorder and acetabular deformity decrease the contact surface and cause intra-articular pressure increase. It leads to development of dystrophic disorders in the cartilage. Correction and maximal possible compensation of the factors mentioned above can slow down arthrosis progress. The primary and secondary acetabular dysplasia. Primary dysplasia is the main sign of congenital hip dysplasia. The term primary dysplasia is used for patients who have not received treatment. According to a number of researchers, the disorder may be genetically determined defect or result of delay of development of acetabulum. The pathology manifests itself in the form is defect of a spatial position of acetabulum and the anterolateral deficiency of the arch. In cases where complete or partial restoration of articular relationship cannot lead to further development of articular components, the term residual dysplasia is used. This condition is characterized by more pronounced flattening and verticalization of acetabulum. Big H deficiency is more common. Secondary dysplasia develops as a result of deformity of dislocation of the head in patients with neurological and dystrophic diseases. Due to structural features, 5 variants of acetabular dysplasia are distinguished. First time defect of spatial orientation of acetabular, the most favorable option for use generally accepted joint-preserving reconstructive interventions. The second type is characterized by increase of width and decrease the depth of the cavity, which develop the functioning of growth zone is disrupted. In the third type, the leading elements of pathology were flattening of the arch, thickening of the bottom, and L-shaped of acetabulum. Vertical deviation of the arch was moderate. Type 4 is characterized by thickening and ossification of medial part of acetabulum, which lead to lateralization. Possible cause is condition is considered a long-term unresolved lateral subluxation and premature loss of U-shaped cartilage. There are 2 subtypes depending on spatial orientation of acetabulum. Type 5 was observed in patients with long-standing marginal or supraacetabular dislocation and was characterized by presence of fibrocartilage fails acetabulum. A distinguishing feature of this variant is that acetabular dysplasia was a soft tissue block that prevented head from the moving into the acetabulum. The severity of acetabular dysplasia is determined by changing of radiometric parameters that determine the depth of acetabulum, degree of inclination of the arch, and spatial orientation of acetabular fragment. The goal of treatment is to prevent early development and slow progression of coxarthrosis, reducing the possibility of endoprothetic at the young age. Is achieved by increasing the degree of coverage of the femoral head, stabilizing articular relationship by restore or improving spatial orientation and shape of acetabulum. The treatment option is determined by age, the degree of and nature of a dysplasia, and the severity of degenerative changes in the joint. There are 3 types of treatment: stimulating, reconstructive, and corrective. Stimulated treatment. There are various often contradictory opinions about the potential of hip joint for post-repositional development. Most authors are of the opinion that the acetabulum retains its potential for formation for up to 2 years until the specified period. Stimulating treatment is applied. It involves mainly conservative manipulation, which primarily includes the remodeling effect of centered femoral head. It is important to accelerate periosteal ossification and improve local microcirculation in the area of the supraacetabular region, adjacent of acetabular cartilage. This minimally invasive intervention is permissible only it is possible to center of the femoral head in the acetabulum. The technique is used in children from 10 to 24 months after restoration of joint relations and present in signs of the unfavorable development of acetabulum. These include age over 1 year at the time of reduction of dislocation, initial value of acetabular index greater than 37%, delayed less than 8 degree, decline of the acetabular index within 6 months after reposition. The technology provides the formation of 6 till 8 wires canals in the supraacetabular area located along the perimeter of the cavity. It's performed twice with interval of 3 months. Clinical result. Reconstructive treatment. Reconstructive surgery provides covering of the femoral head with hyaline cartilage by changing of spatial position of sternum, its shape and arch. Mandatory condition for reconstructive surgery: possibility of femoral head centration in the sternum, sufficient range of the motion not less than 50%. We consider radiographic parameters and choose optimal method of correction in order to perform reconstructive surgery as shown in this slide. There are three types of reconstructive surgery: reorienting, reshaping, and combined procedure. Surgical correction of acetabular dysplasia is indicated in case of articular correlation disorder, laterally proximal displacement with moderate or severe dysplasia, regardless of the nature. In absence of decentration, the surgery is performed for severe residual dysplasia as well as for primary dysplasia in patients over 16 years, in presence of clinical manifestations and absence of positive response of conservative treatment. In patients 2 to 4 years old, the degree of dysplasia is determined by cartilaginous landmarks. Surgeries are contraindicated in cases of third grade of arthrosis and significant degrees of volume of the acetabulum. When performing a surgical intervention in patient with hip dysplasia, wire and half pins arrangement of apparatus that contain femoral and pelvis module are used. The choice of bone fixator and the optimal number of supports is determined on the patient age and volume of the surgery. Femoral module consists two supports, on one of which is located on the level on the middle third of the femoral diaphysis. The second ring is placed on the level on the distal metaphysis of the bone. It is possible to use wire and half pins methods of fixation. Pelvic module is used in three variants. In children 2 to 4 years old, an arch wire support is used, which installed in the oblique plane. Oblique wires are used. A feature of wires in the mandatory placing through the widest area of the bone tissue at the level on the iliac tuberosity and auricular surface. In children under 9 years, 3, maybe 4 cantilever wires and 1 and 2 half pins are used as fixator. Cantilever wires with a lever carried out in the above way through the posterior spines of the ilium and the intraosseous notch in the direction of anterior. The wires is beaten on the near the ilius, which will sink under the skin. The intervals between the exit points of the wires, 1 to half pins, are inserted in the front part of the wing. In the patients older than 9 years, sufficient thickness of iliac wing allows to use only half pins. As a rule, when we make pelvic surgery, we put the apparatus on the both sides of the pelvic. Reorienting surgery. In young children, the most effective and physiological method is a Salter operation, which involves dissection of the ilium at the level of the anterior lower spine, followed by rotation of the distal fragment along the acetabulum downward, anteriorly and outward. It's known that the effectiveness of this operation decreases after 6 years due to the increased rigidity of symphysis around which acetabulum fragment rotates. However, in the younger children, corrective intervention options are limited. The amount of possible lateral incline does not exceed 15 degrees. In patients 2 till 4 years, this does not have a significant effect on the results, since during the period the possibility of postoperative remodeling and deepening of the acetabulum remains. In children over 4 years, indication for surgery is determined by acetabular indices and acetabular coefficient. When using Elizarov method, it is possible to perform an isolated lateral tilt of acetabulum. In this case, the degree of correction of acetabulum index after surgery can be 30-35 degrees. The distinguished feature of the hardware technology is the ability to simultaneously perform operation on the both sides. The use of the lane shape osteotomy of the ilium and external fixation device expands the age limit to using the technology to 8 years and increase the correction capability. Indication for surgery is regulated by a degree of flattening of cavity. In children older 6 years, as a rule, we must make pelvic osteotomy. The proposed option of triple pelvic osteotomy differs the level of the intersection of pelvic bones. The mobility of acetabular fragment primarily depends on the location of ischial osteotomy relative on the ischial tuberosity ischial spine. The greatest mobility for the cavity is achieved when the ischium is crossed above the ischial spine, like Tony's surgery. However, the increase of this increases the technical complexity and intervention and increase the risk of damage of nerve or vascular formation. Pelvic osteotomy, according to Steele, Lecoeur, that involve intersection of ischium medially from the ischial tuberosity, are distinguished relative simplicity and the technical execution. However, the inclusion of ischial tuberosity and spine to the acetabular fragment leads to significant limitation of mobility due to action of ligamentum sacrotuberale and sacrospinale. Performing the osteotomy over the ischial tuberosity allows the neutralize the influence on one of the ligaments without increasing the technical complexity of operation. According to Javish, it is advisable to supplement the triple osteotomy with transection of ischial spine. Reorientation operation also include complete periacetabular osteotomy like Wagner, Ninamea, Gans. This intervention provides more optimal mobility for acetabular fragment, and advantages of the beneath osteotomy is possibility to medialization of acetabulum by crossing the pubic bone. Pericetabular osteotomy is characterized by significant technical complexity and trauma. They are used mainly in adult, regardless of the nature of bone intersection. The mandatory condition for use the reconstructive reorientation intervention are moderate flattening of acetabulum and corresponds the size of the head to volume of acetabulum. We perform pelvic osteotomy and apply Elizarov frame starting from 8 years. Exclusion the children with pertussis disease. In those cases, we perform pelvic osteotomy regardless of age. In puboschiatic synchondrosis is presented double pelvic osteotomy according to Mackay is used which involves crossing only ilium and pubic bone. We apply the technique pelvic osteotomy according to the time of bone corresponds the method Steele and Carlios. Unlike classical invasions, the transosseous osteosynthesis applies this operation practically don't differ by amount of achieved mobility of acetabulum. Application of Elizarov frame helps to overcome stabilized effect above mentioned ligaments. Still, surgery is considered technically simple and relatively minimal invasive one. In same time, we must note that the invasion is accompanied by considerable deformity of the pelvic ring. We prefer the method Carlios in cases where the necessary significant tilt of acetabulum in the sagittal plane. Duration of fixation in cases of iliac or pelvic bone osteotomy lasts about 50-60 days, regardless of the method of acetabular fragment transport. Unlike many authors, we believe that using the several approaches is not a disadvantages of technique. The slide you can see osteotomy of pubic and ischial bone from one and two approaches. This operation approach is performed through the intramuscular gaps and do not pressure crossing or mobilize any muscles. The feature of our technology is a method of transposition of that stubble is done by changing position of the femur, which in which apparatus is connected to osteotomized pelvic fragment. The technique is described by Padovani rather long ago. The attitude to its skeptic, we have different point of the view. Position of femur provide containment of the head into the stubulum, determines the degree of expanded correction, turns the stubulum fragment, which done in the turn to frontal, sagittal, and horizontal plane. Pre-operative planning is simplified and which most essential to plane transposition of stubulum is made easy. Unpredicted deviation of the stubulum fragment is ruled out. Transposition of stubulum dome is performed according to the same principle. Reshaping osteotomy. Incomplete periacetabulum osteotomy, this category belong like Lance, Pemberton, Degas, and Diego osteotomy. The surgery allows the change orientation of stubulum dome and decrease its volume. The inclination of osteotomized fragment is carried out due to the U-shaped cartilage. They provide a greater reduction of stubulum index compared to Salter surgery. However, they used to correct or pronounce the effect of special position of stubulum is not advisable due to the risk of deformity of the arch. Therefore, this intervention should not be considered as an alternative to orientation operation. Another disadvantage of this surgery is premature closure of U-shaped cartilage. The main indication for isolated use for an incomplete periacetabulum osteotomy is considered the flattening of that stubulum, a discrepancy between the volume and size of femoral head. The use of external fixation device expands the age limit of the use of incomplete periacetabulum osteotomy. In patients over 12 years, the osteotomized fragment is still through the subchondral fraction in the inner part of the fragment. Gradual or immediate deviation of the arch is possible. There is not need to some transplants, and fixation period varies from 45 to 60 days. In cases with severe development and deformity of stubulum and incongruity of articular surfaces, combined interventions are used. When increase the congruence index and of articular surfaces, combination of reorienting pelvic osteotomy and incomplete periacetabulum osteotomy is used. Due to pelvic osteotomy, stubulum fragment is tilting in frontal, sagittal, and horizontal plane. Due to incomplete periacetabulum, there are an additional lateral tilt of arch of cavity and change its shape. When the congruence index decreases and combination of reorientation osteotomy and shelf procedure is used. This intervention occupies an intermediate position between reconstructive and correction operation. Pelvic osteotomy can be combined with incomplete osteotomy or shelf osteotomy. More often intervention is performed at the intervals of 2 till 3 weeks. The average fixation period is 60 to 70 days. Corrective operation is indicated in cases where it is impossible to achieve centering of femoral head in stubulum or significant incongruence of articular surfaces. Unlike reconstructive surgery, they provide coverage of femoral head with metaplastic articular capsule. Corrective intervention includes shelf procedure or supraacetabular osteotomy. Shelf procedure involves increase the coverage of the head through the use of outer graft and it's installed anterior outer part of the supraacetabular region. Operation can be used in children over 6 years. indicated for pronounced flattening of acetabulum and discrepancy between the volume and size of enlarged hair, the regulating parameters should be considered the vertical deviation of angle, lance angle. When performing the Kyrie operation, medial and proximal displacement of distal part of case through the rotation of symphysis pubis, covering of the femoral head is provided by osteotomized surface of proximal fragment and internal capsule of the joint. The operation is indicated in adolescent and young adults with pronounced thickening of acetabulum and lateralization of the head and moderate discrepancy of the size and articular surfaces. Since the intervention is accompanied by verticalization of acetabulum, it's not advisable if the lance angle is significantly reduced. In cases of severe deformity and increase the size of head, femoral head, supraacetabular medializing osteotomy are supplemented by shelf procedure. When performing the corrective intervention, fixation lasts 30 till 40 days. Its aim is decompression of the joint. Clinical examples. They use innominate osteotomy in patient of 2 till 5 years old with first time of dysplasia. In all observation, good development of the acetabulum is not after torsion and stabilization of articular relationship. Clinical examples of performing innominate osteotomy in older patient with bilateral hip dislocation. In patient with marginal dislocation, osteotomy of the iliac bone was performed simultaneously in both sides, which is quite difficult when using standard technique. 9-year-old patient with secondary acetabular dysplasia due to aseptic ascites. Double pelvic osteotomy was performed, and you can see satisfactory condition of the joint after 16 years. This patient, our colleague. 16-year-old patient with residual acetabular dysplasia and after surgical treatment of congenital hip dislocation is term of the level of bone intersection pelvic osteotomy corresponds to Lecoeur technique, which is considered as like variant of puboiliac osteotomy. It is mistake. But since the inclination of the cavity was accompanying the displacement of fragments of pubic bone, in this case, gradual transposition of acetabulum was performed. You can see result after 8 years. We rare use the gradual transposition of acetabular fragment. 12-year-old patient with residual acetabular dysplasia after reconstructive surgery, pelvic osteotomy was performed, and you can see result after 12 years. 31-year-old patients, female patients with primary acetabular dysplasia, pronounced flattening and lateralization of acetabulum. Indication for reconstructive interventions is questionable due to the incongruity of articular surfaces, signs of arthrosis, and the age of patients. Osteotomy of pelvis ensure restoration of stabilization of articular relationship and did not cause the decompensation of articulation. You can see result after 4 years. Examples for performing of complete periacetabular osteotomy. The intervention ensure optimal mobility of acetabular component. Transposition of acetabulum is carried out in manner described above. When performing this intervention, combined fixation is used. This allows to reduce the period of fixation to 30 till 40 days. The main purpose of this fixation is decompression of the joint. But even the use device does not solve problems associated with discongress of articular surfaces. Examples of performing incomplete periacetabulum osteotomy in 13-year-old patient with severe deformity and flattening of acetabulum. As a result, the intervention, the acetabulum acquired the spherical shape, which ensure congruence of articular surfaces. And 9-year-old patient, the technology of gradual acetabulum formation was used. You can see good result after 19 years. Examples of using combined operation. 8-year-old patient underwent the innominate and incomplete periacetabulum osteotomy due to pronounced flattening of acetabulum, and 14-year-old patient with residual acetabular dysplasia in the form of significant flattening and verticalization of acetabulum, pronounced incongruence of articular surfaces, and combination pelvic and incomplete periacetabular osteotomy was performed. Treatment result after 7 years. Oh, in this slide, you can see the example of simultaneous combined intervention in a 15-year-old patient. In 18-year-old patient, she has severe acetabular dysplasia accompanied with formation of false acetabulum. Congruence index 0.75 and open reduction was performed, and stabilized joint reorienting surgery was performed in combination of shelf procedure. You can see the anatomical result after 3 years. Examples of combined intervention. 70-year-old patient, residual hip dysplasia, underwent pelvic osteotomy and combination with shelf procedure. And 15-year-old patient with defect of proximal femur due to severe incongruence articular surfaces underwent the combined corrective intervention, chiriosteotomy, and shelf procedure. 20-year-old patient has severe deformity of femoral head combined with flattening of acetabulum. The head reduction osteotomy did not provide sufficient coverage of the femoral head. Shelf operation performed, positive outcome after 2 years. And last patient, 23 years patient with consequences of septic ascites, has pronounced incongruence of articular surfaces. Modeling osteotomy of the femoral head and chiriosteotomy was performed. Result after 1 year. Conclusion. Differentiated and justified application of joint procedure technology ensures the restoration and stabilization of joint relationship, helps to prevent an early development of degenerative changes in joint. In developed osteoarthritis, reconstructive and corrective intervention can slow down the progression and delay arthroplasty operations. The use of devices for external fixation expands the age limit and indication for surgical reconstruction, increase the capability of non-corrective technology. Thank you for your attention.
The topic is very difficult. I don't know how many of you have understood the everything. The cases that he has shown is very difficult cases. How to treat with the Lizarov apparatus and technique. Most of the cases that you are sitting here, probably for you this is unknown. How do of them, those who are sitting here, do you do any kind of hip dysplasia by Elizarov here? Anybody? Please raise your hand. Only one person. 2, 3, only 3. So this man is doing for the last more than 40 years. You are working, more than 40. Near about 40 years he is working in Kurgan Center, and fighting all the time with these kind of difficult cases. So today you will be able to learn in the bone demonstration, and most of the orthopedic surgeons, we are doing open surgery at the age of 6 months, 8 months, 1.5. He's applying Ilizarov at the age of 2. And I asked him before that, at the age of 10 months, he started doing Ilizarov. But 2, 3, 4, 5, he is doing Ilizarov. And normally, we are opening and we are cut shorting the femur size if it is needed. If 6 months, 8 months, sometimes you don't need to go for any kind of open reduction, Somerville operation, most of the surgeons you do and I'm doing. And at the same time, I'm doing also Ilizarov surgery in 3, 4, 5, 6, 7, 8 years old. And I asked him the question, do you do PSO, pelvic support osteotomy, at which age? Up to 16, after 16 years, he is doing the PSO, 16 to 30 years. If you have any questions, you can ask to him after the lecture. Any questions you can ask.
Hello. Yeah, my question is, when you do the supraestabulum osteotomy, the most of the cases I found there is a gap is there. And he fixed with initially he was fixing with the wires, now he is fixing with the screws. So how he covered that gap?
Поняли? Когда вы сделаете супраэпсидуральную остеотомию, вы там кости даете внутри или вы скрутно фиксируете?
Нет, мы трансплантат не используем.
He is not putting any kind of transplant, that is bone graft, no. But after doing this supraacetibular osteotomy, opening which he is fixing with the wires or with the screws.
Second thing, what he is doing in DDH, because it's a very problematic case for us, we do open surgery. So he does, how he correct the DDH in children?
Вот дисплазия, который, как вы вот этот коррекцию, вот коррекцию, поднимаете вниз вначале, потом поставите аппарат или как?
Сначала ставим аппарат, после этого центрируем головку во впадине и после этого выполняем необходимый набор остеотомии для того, чтобы поставить впадину в правильное положение.
Then your question is how he is correcting the DDH patient. I told before that at the age of 2, 3, 4, 5 years, he is applying the apparatus with the ilium and the femur, just bringing down the head up to the acetabulum. And whenever he is looking that this is up to the acetabulum, he is doing the osteotomy in the lots of osteotomies, Pemberton, Chiari, and just covering the shelf and putting with the Ilizarov apparatus.
Actually, after coming from Kurgan, I was working with him. So I've tried many times DDH, but I couldn't success. So
He could not success.
Yeah.
Он работал там, Курган и видел, но он не получает хороший результат. Но что отвечаете?
Почему?
Why you are not getting result? Because you are not doing properly, he is telling.
Yeah. Second thing, does he have any role of the avian cases where the hip is upward goes there?
Yes.
So avian he is doing something?
Вот некроз головки бедра бывает ли, когда вы вот этот тянете?
Если во время лечения у вас получается некроз головки бедра, значит вы не обеспечили достаточную декомпрессию сустава. Достаточная декомпрессия сустава обеспечивается с помощью аппаратной декомпрессии, укорачивающей остеотомии, правильного положения головки во впадине.
You will get AVN of the head
Yeah.
If you don't properly distract the head of the humerus, properly if you don't do it, if you don't follow the biological parameters of the Ilizarov, then you can invite the avian of the hip. So you must do gradually, bringing it down up to the acetybulum, and you must see the shape of the head. And then whenever needed, you go to the osteotomy, either Pemberton osteotomy or Chiari osteotomy. Just you should have to cover the head. That he has shown in the lots of pictures.
Yeah, in the avian, usually subluxated upward. So,
Necros, как головки бедра получается, он говорит. No?
Некроз головки бедра получается в том случае, если после вправления в суставе появилась или осталась компрессия.
If you will get necrosis of the head of the femur,
yeah.
when you will get this head of the femur in the acetybulum and it is compressed, then you will get the avian.
Does distraction help a lot in
No,
avian?
distraction, you are bringing down the head of the femur up to the acetybulum. After that, you have pulled this one to the acetybulum. And if you compressed, then you will get avian.
Thank you.
Компрессия, разгрузка сустава проводится в течение всего срока лечения в аппарате. То есть не только в момент вправления, а вообще постоянно.
Yes. Another important thing he is telling, during whole time of treatment, when you are bringing down, you must maintain the decompression of the head of the femur in the acetybulum also. So you are satisfied or not? I told, he is telling, not I am not telling, just I am translating. He is telling me that during whole period of treatment, when you are bringing down the head and you have put it to the acetybulum, at that whole time you must maintain the rule and you cannot press or compress the head over the acetybulum. Distraction of, but it is out of the center and head shallow. His head is not normal position. That's why you should have to cover the head by doing the osteotomy. Now we'll go in the demonstration. Any question to anybody?
Please.
Now Dr. Agarwal is going to question.
Yes, please. Is this alternate for pelvic supportive osteotomy or not? Is this method alternate of pelvic supportive osteotomy?
Do you do the pelvic support osteotomy? On Jalet, no, Vozrast, age is 16. Sometimes he's doing at the age of 12, 13, 14, depending upon the case. But his advice is PSO from 16 to 30 years, this old DDH is better not to go for this total hip surgery. Okay, you are satisfied?
Thank you for visitation. Just I'm asking about, you showed the case
Now,
2 years.
yes.
About the 2 years. We need to open or not open?
Note, he is not opening.
Close?
Close method, bringing down by putting the Lizarov, coming down and then put it into the, gradual distraction.
So if there is something inside ball veneer, like soft tissue or thick ligament.
Внутри есть мягкие ткани. Что делать?
It is depend of type of dysplasia.
Yeah, there is something inside the sternum.
If we have 5 type with soft tissue block, we must open and remove.
If it is type 5, then you should have to open, you are bringing down and you just clear the acetybulum, open it and then put it.
So if there is something inside, we need to open. How do you know there is something inside? You make arthrogram?
Type 5, bone acetybulum is not in the normal shape.
Not in the normal shape.
Yeah. Type 5, he is telling. If it is not type 5, he has classified into 5 types, then bring it down and put.
Okay. Another case, this is 18 years age. He make pelvic osteotomy and the head and the sternum is deformed and he make more, and the X-ray after that is also deformed. What is the result? The result, there is stiffness after the operation.
Você
Because
nasce
of the age is
de
18
Catherine
years.
Pakazali, rezultat
And the
ka
X-ray the same, before and
Do
after.
operații, posle operații, adina ka
Just
bon
only
govori.
covering.
Можно включить этот?
That one he wants to show the question that he is eating. Last slide. Oh, he will show it during the work.
Yeah.
Now,
Case of 18 years.
okay, he will show during the workshop. Open that one and we will show you that case.
Okay, thank you.
Now, Arya Agarwal is going to talk on PSO. You are eating?
I'm going to tell about the pelvic support osteotomy. This lecture I was giving in Kurgan. They have called me to give this lecture. Dr. Srinivasan, where he is? So he is sitting there. He was listening my lecture in Kurgan. So he has started to do this pelvic support osteotomy. So it's a very, very interesting topic, very, very useful. This girl, 18 years, having infection in her childhood, what you will suggest that I asked with them, orthodesis, resection osteoplasty, and THR. What the whole hall, what does it recommend? Dr. Meena, what do you think? So mostly people in many countries, I have given the lecture, even in the USA, everyone was telling me that you have to do THR, whatever pelvic support osteotomy you do, in 5 to 10 years, it will be failure. What is your opinion? What is your opinion? Anyhow, I'm showing you. What is the indication of the pelvic support osteotomy? Hip instability in young patients, commonly due to old septic arthritis, neglected dislocation hip, and old pathies. What is the aim of the pelvic support osteotomy? Restore hip stability while preserving biomechanical alignment of extremity, to overcome hip pain, equalize limb length discrepancy, prevent limping, improve range of the motion of the hip. Main objective of the pelvic support osteotomy is to correct Trendelenburg gait. This is the main criteria. Before surgery, Trendelenburg gait was positive. If after the surgery, Trendelenburg gait correct is there, then it means your surgery is successful. There are 3 steps in pelvic support osteotomy. Femur is adducted and proximal femoral valgus osteotomy is done at the level of the ischial tuberosity. Number 2, distal femoral varus osteotomy is done. Number 3, femoral lengthening is done at the level of the distal osteotomy to equalize the limb length. For example, Okay. The first question is that where you will do the osteotomy. In the operation theater, you adduct the limb where it touches the acetabulum, ischium bone, you will do the osteotomy. This is first system. I will show you how much valgus to be done. Second question is that all over the world, they were doing the osteotomy just close to the first artery, but we have changed on the world. I'm the first person who have changed the scenario, and after that, okay, this is the first step. Second step is done when osteotomy is done. Okay. Okay. Second step is done when osteotomy is done. Then we do second osteotomy at the distal level. Our main aim is that when we do the osteotomy, the center of the knee joint from here shall be equal. There should be no length discrepancy. If you do that, it means your surgery is successful. We have 5 questions. Where should be the first osteotomy? What should be when you do osteotomy? What should be the valgus and extension? How much degree valgus is done? Number 3, where is the second osteotomy? And number 4, what should be the magnitude of the varus? If you are doing the varus, how much varus to be done? Number 5 is how much lengthening should be done. When you start the pelvic osteotomy, these 5 questions should be in your mind. So this I have told that you in the surgery you adduct the limb, and where it touches the ischium, there you should do the first osteotomy. Another is how much valgus to be done. Tell the patient to stand on the affected limb. So you will find there is a pelvic drop is there. So you measure what is the pelvic drop here and here. From here, this is 33 degree in this case, and 5, 10, 15 degree. If there is a contracture, you have to add that. So this is now very clear how much abduction to be done, how much pelvic drop is there. That should be the abduction at the first osteotomy. Second osteotomy, how much to be done? This we have developed that. What we do is a software is there, manipulative software is there. With that, before surgery, you do the abduction at the femur bone and then take this limb at the opposite direction and then draw a curve there. Wherever it touches that limb, previously every book has told that you do the osteotomy. In very country I have gone, but that is not there. Where this touches that limb, that should be the level of the osteotomy. There are various formulas. They are here. They show here x1, x2, and y. Where you should do the osteotomy. Y is equal to x1 minus x2 oblique sine theta. So y can be calculated. There's theta into 1 into 2. That is the mathematical calculation where you do the second osteotomy. So this I have shown the x1 and x2. Here is the second osteotomy. So the point of a sectional femur with contralateral femur, this level can be determined using the image manipulation software. There are so many software that before surgery, how much abduction is done, and here you calculate that. This level should be the second osteotomy. How much varus is done than the center of the knee joint and the same distance from the midline of the central bone, that is to compare with the contralateral side. This is a bone model. So what we do, we will show you here, we will do the workshop here. So here is the first osteotomy at the level of the ischial tuberosity. And this is the second osteotomy done there, and the whole is connected with the frame there. There is other formulas there that it's a A1, V0. These are the other formulas why we collect the osteotomy. This is a girl. This case I have done about in 2004. 18-year girl, septic arthritis. There is no head is there. You can do 3 centimeters shortening is there, and you can see that she is walking with the limb. Basically, Trendelman gait is positive in this case, and there is a 3 centimeters shortening is there. It was very big. Parents were very worried because the girl was 18 years. So, I didn't. This was the case of 2004. Anyhow, we have performed the osteotomy, pelvic support osteotomy here, and then according to that formula, we have done the second osteotomy here, there, and whatever shortening was there, that we have calculated by the knee joint level, that lengthening was done there. So first osteotomy was done, second osteotomy was done, and the lengthening was done at the second osteotomy. So you can see that it's a perfect limb. Trendelenburg gait is not present there, and she has got the fully length discrepancy covered there. You can see before surgery, Trendelenburg gait was positive. After surgery, there is no Trendelenburg gait. You can see the movie here. And after post-operative video. So this was the pre-X-ray, and you know the pelvic, the femur which have done the abduction osteotomy, while she is walking, this is done supporting the pelvis. So we have done the long X-ray, final X-ray after pelvic osteotomy showing equal distance from the midline. Both knee joints are at the same level. So final X-ray after pelvic osteotomy is showing equal distance of the knee from the normal weight line. So we are following this girl. After 17 years, after 17 years, this girl came to us. She told her, I was working in the film industry and I'm going to marry that. So after 17 years, we show you how much normal this girl is there. This was an initial X-ray. After that, X-ray is there. You can see that the movie after 17 years and after 17 years. You cannot detect. We are following this girl and now she got married. So this is a wonderful technique. Only thing that it should be calculated, and she is doing the job, so we have changed her life there. So I'm going to show you how to do done here. It's a fantastic. Dr. Meena, this girl is fantastic. Okay. Her parents were married, nobody can detect that this girl is having any complication or shortening or anything there. The other case was having the subluxation there, so he was operated. It was how much walking there, walking with the limb. So in the same way, we have done osteotomy and the second osteotomy here. And this is the final X-ray picture is there. It was a pre-surgery and this is a final. You can see that. This is another girl of polio. Without support, it's very difficult because the head was subluxated here. Normal head. In fact, polio case, there is no subluxation of the, no formation of the acetabulum there. And you have seen a lot of cases of Tepalanki. So, what we thought, and there is shortening of the 4 centimeter here. So, in the same way, we have done the osteotomy. And the lengthening was done. This was the pre-surgery and after this. So main thing was the pelvic support was done here. So when she walks, so this portion support that. So now she is leading a normal life there. You can see beautifully the pelvic support osteotomy was done here. So another case, I don't know what was the diagnosis. You can see that there is a avian, there is a no articular cartilage is damaged there. She was walking with a painful limb. So what we have done, the tendon gate was positive. So we have applied the frame and we have done the osteotomy here. We thought that when we will do the osteotomy here, it will increase the circulation of the hip there. So close to that, we have done the osteotomy and in thought that it will increase the circulation. So, you know, the tendon gate has become finished. Now this girl is looking very smart and whole thing with the short was there and you can see that before surgery a lot of vascularity and cartilage regeneration has been formed there. So now see, it means the osteotomy and distraction, it increases the vascularity and regeneration of cartilage is formed there. So this is the case of old septic arthritis. I heard the lecturer, Dr. Professor Topalanki, that if you stimulate that, new bone can form there. So, tendon gauge is positive there. You can see we have applied the pelvic support plus lengthening there, here. So, we're surprised to know the head, which was not there, regeneration of the neck has been formed there. It is supporting there. And you can see that there was no neck either there. Here we have got that neck there. This is the, before that she was walking there and after that, she is walking, the child is walking perfect. Total number cases were 27, average follow-up for 18 years. Result, Trendelenburg sign will last in 25 after 27 patients. Link disappeared in 23 out of 27 patients. Average union time was 3 to 5 months. Only the complication in one case is in which we have done the acute correction of the varus, second osteotomy. So she has gone into the non-union, we have done the plating. Now what we are doing, we do second osteotomy, apply the hinges. So by forces, they shape the varus there. When they are stretching it done because there is abduction. So lot of forces are working there. They produce the varus automatically. We do not produce the osteotomy at the second osteotomy. The pelvic support osteotomy is an excellent alternative to arthroplasty or orthodesis. Young patient with challenging hip instability. Pelvic support must be considered as an alternative in treatment of young patients with hip instability. And we are following, because in that girl, the follow-up is of 17 years. It means still she is coming to us. Up to 20 years follow-up was done. The patient will walk with a normal line. Thank you very much. वर्कशॉप कराना पहले तो पहले. Any question, please?
Hello, sir. Just one question. I have experience of cases done here, doing excellent for 7 years in here. What is the ideal age? Because some loss of angulation is there with the weight. So, in your cases, you have seen a younger age group also. So, what's the recommended age? But your experience, sir.
What is?
Recommended age when to do the PSO.
Actually, what I say, if you have done it to 5 6 years, so then you have to do again the surgery.
Right.
At the age of 15, 16 years. So if the child is there for 6, 7 years, so one should explain that at the 15th year we have to do the again osteotomy. Yes.
I must congratulate Dr. Agarwal. It's an excellent procedure to stabilize the hip in the pediatric age group. And often we get the patients of post-septic arthritis and necrosis of the hip in abnormal position. In such patients, I routinely do Gudderson excision arthroplasty, and after waiting period of say around 6 to 8 weeks, pelvic support osteotomy. And number two, these patients often faces the problems of the stiffness of the knee. So as you regenerate forms, you can remove the fixator early and can slide the plate, amount of the varus you want, you can bend the plate and slide the plate and take out the fixator. And at that time, you can use your Bristow elevator to elevate the adhesions on the bone so you can mobilize the knee very next day. So it's a very, very common complication, stiffness of the knee. And it's a very excellent procedure for the pediatric age group patient.
First of all, sir, we do not do any surgery because the child infantile infection comes early age. So what we do, we just wait for 3 years. Because before surgery, if we do they cross the bone, does not slipping of the screws and other things take place.
After years, 8 years.
Yeah. After 3 to 4 years, we can perform the surgery. And I tell you, if you do the pelvic support osteotomy, in most of the cases, regeneration of the head took place at the early age. And after that, one have to explain that we have to do the again surgery at the age of 15, 16 years. Thank you very much, sir. इसके बाद दिखाना पड़ेगा ना. हाँ.
So, Dennis, what will you be doing now? Which technique? Which technique now? What are you going to do? No, which osteotomy? Any particular osteotomy?
Oh, thank you. So, dear friends, now this is the high time just to see how to put the acetybulum in the ileum. Most of the orthopedic surgeons, they are afraid of doing that. Elizarov surgery is so beautiful, so fantastic, because you are playing with the wires all the time. You are playing with the wires. Now you just see how to put the wires in the ileum for dysplastic hip and osteotomy. Try to keep it in your mind how to do that, and see the Professor Toplenki now. He is going to show you the important steps of the acetibular dysplasia in DDH. How to do that you can see now. So, это положение больного, вот в каком виде будет больного?
Ну вот если он сейчас вот так лежит на спине, то
Да.
здесь он будет вот в таком положении.
Это положение так, на боку, on side. The first you should have to know the position of the patient. See, he is on the side, patient, he or she on the side. Дети.
А или нужно?
Мгм. Это какой стороны? Anterior superior spine? Нет.
Это
А,
ушковидная, это самое. Вот оно.
Алием. No,
Это-
this.
Нет,
Yeah, stem. Yes. From the stem. Now, see, this is the ischium. Is there any neurovascular structure here?
No.
No. So, safe corridor. This is not your hip, your patient's hip. So, you can introduce the wire. See how he is going through from the ischium to the whole ileum. He is crossing the wires. Нет, еще нет, дальше, еще дальше. Все нормально? Все. Окей. Now, second wire, 3 fingers. You see the 3 fingers or 4 fingers from the first wire. He has put the knot wire in the olive, and then olive, second olive. Same way, есть вверху идет не проблема.
Самый раз.
Окей?
Вот она так и должна проходить.
Ага.
Даже изогнутая. И
Ага.
она полностью в сельского проходит.
This is the concave area. So you see, can you see in the camera? See, okay. very important thing is that so that we can put the wires in that direction. See, these are the two olive wires. Стержень будете поставить там? Стержень.
Здесь 2 стержня поставим. То есть это не на ребенка, не на маленького 4 спицы и дуга. А если на ребенок среднего размера, то в этом случае у нас будет...
Это возрастному вы поставите? Какой спицы дают, на сколько лет?
Это до 10 лет.
После
10 ставить нельзя.
После 10 поставить нельзя. Что нельзя?
Спицы не надо.
Только стержень.
Да.
See what he is telling. Up to 10 years, you should have to put the wires. After 10 years, it is difficult for the children. After 10 years, you will put the pins. Up to 10 years, very easy.
После 10 лет, если ты правильно провел спицу, ее крайне сложно убрать взрослого человека. Поэтому лучше не ставить.
No. Better not to put the wires after the 10 years age. Now this is adult after 10 years. That's why 2 wires and pins, 2 pins. 1 pin is putting now. In the only pins. Telling. After 10, if you pins after 10. Держи.
Аппарат устанавливается на центр 4 до 10.
This technique, these wires and pins, we can apply at the age of 4 to 10 years old.
Спицы откусываются здесь.
Now, see, you have seen the olives from, you cut up to the olive, you just remove the wires and see. Now you put the arch, 120-degree arch. These are all thinking. All thinking. Galava means it. Galava. This is in Ruski. You must learn Russian. Galava. Galava means head. Russian? Galava. Надо головой работать. You must work with the brain. See? Galava. Hmm.
Расстояние между кожей и вот этой,
Должен быть
ну,
3
максимум, нет,
Сколько?
сантиметра 2 максимум.
Maximum. The distance between the skin and the ring or arch, maximum 2 centimeter. 2 centimeter. This is the mass of everything. 2 centimeter. Write down. Write down in your paper. Otherwise you will forget. And you will go back, you will put that 10 centimeter. 2 centimeter. Huh?
How do you know it's in the bone?
Oh, when this is cancellous bone, easily you can feel. Topography. Siam, you can use. No, you use here. No. When patient would lie in the lateral side, you can put in the Siam. Yes, lateral position. Lateral position, yes.
Значит, аналогичная опора устанавливается на другом крыле.
See, same apparatus, because you have two ileum, two sides. Same time, same apparatus you should have to apply in the opposite side.
You have again lateral. What position? If it is lateral again.
Again lateral. No, lateral. This is lateral, see, ischium, not supine. Because a cerebellum will be up. Now,
How he can be lateral again?
lateral, yes. See.
Где-то что? Так, вот это у нас
Mhm.
вот так.
Ah.
Какой должен? Понял.
Это право.
you change the opposite femur? Opposite. Left femur.
Это left, это право, да.
Мы можем проделать
Да.
все.
Left foot.
This won't come in the picture in the way.
Нужно будет провести бедро.
Any? Please, microphone.
You are fixing the ileum with the pins. Can you go through the physis also, crossing the physis? Crossing the iliac physis, epiphysis?
What is epiphysis? Here.
You are
Epiphysis.
passing the pins through the ileum. So you are
Through the
crossing.
ileum.
You are crossing the physis in the children's also, no? So you can go through the physis.
No problem with this.
You are using the fixate in the children's.
Damage of apophysis, epiphysis. Там же что-то проблема делается, когда вы... Нет, no. For children, no problem. Study. Next. Это право или лево? Это...
Тогда сам нужно будет сказать, что сегодня уже показывали, как ставится аппарат в бедро. Поэтому мы время не будем тратить с установкой аппарата.
Хорошо, это bridge.
Мы просто фиксируем.
Today you have seen how we have applied apparatus in the femur. Now, we don't want to spend more time.
Так, чтобы оно воткнулось.
Uh,
Сейчас я ее поставлю.
Left side.
Left.
Главное, чтобы она вперед не выходила. Пусть она назад выходит.
See.
Бедро устанавливается с учетом того, как мы должны развернуть эту стаблю, чтобы она хорошо погружалась, чтобы не было никаких эксцессов, то есть это отведение, внутренняя ротация, сгибание.
You must see the position of the head of the femur in the acetabulum. Whenever your head in the acetabulum, no rotation, no varus, no valgus. You must put the head in the acetabulum and then you fix it with the that side, up to the head. See. The, вы фиксируете вот этот, да? Хорошо? Yes, okay. Oh.
Why olive? Why there should be olive?
This is spitz normally. Почему olive? Нет. Просто взял. Normal. Nowhere. He has taken just. Forget about it. All smooth wires. No olive wires. So, сколько должен быть? 4, да?
Обычно, когда нормальную операцию делают, то еще сюда проводят вот так. Но поскольку у нас здесь нет аппарата, мы точно не поставим.
Хорошо.
Туда? Да.
Хорошо.
Нужно акцентировать внимание, что, естественно, спицы не должны выходить на переднюю поверхность головки. Они должны выходить внутрь или на заднюю часть.
You must pay attention so that you don't violate the rule. Don't pierce through the head of the femur. Don't pierce.
Don't pass.
Yes. Don't pass through the no. Backside. Через головки нет, да?
Почему? Лучше всего, чтобы она по заднему краю.
Posterior.
Если она попадет в головку, ничего страшного.
It is better to put the wire in the posterior side. If you go through the head, nothing to be worried. Фиксируйте, да, чтобы болтаться не было.
It should be in neutral position.
Neutral position, this position.
Half pin.
Half ring.
No, half pin.
Half pin. Давай. Туда. Okay. Okay. No, Saurabh болтается. Strong. Не так и strong.
Чтобы он не в этой проституне.
Это не будут мешать. Там дырка есть.
Значит, как было в этом? Показано на слайдах, сначала выполняется сутенер.
Ишкил.
Да.
Лонный. Лонный это
лонная кость.
Лонный кость. Пивис.
Доступ к ней осуществляется через поверхность длинного аддуктора.
That's it. First step, you see, we are doing the osteotomy here in the pubis. First osteotomy. Okay.
Incision.
Incision. You'll make incision, then here you'll go with the osteotomy. He's swelling. Incision. Without incision cannot be. Skin. Yeah. The second.
Под длинным аддуктором достигается седалищный бугор, по нему смещается вверх и выполняется подгон 45 градусов.
So, это будем.
Седалищный.
Ischium. Now, 45-degree angle. We have done the osteotomy with the 45-degree angle in the ischium. Two, one in the pubis, another in the ischium. Triple osteotomy. О, уже ушел. Хорошо, удаляем тогда.
Сейчас мы сломаем ее.
Okay. Now, this is the third osteotomy in the pubis, in the ischium, and ilium. Now your leg in normal position. See. Now you go for разгибание, that means extension, and you go for rotation correction.
Если есть необходимость, которая определяется по снимку, то можно сделать идеализацию.
If you see that you should have to go for any correction, then you can go for medialization, because you have done the triple osteotomy, and whatever you like, you can do.
Если есть необходимость, допустим, улучшить заднее покрытие, то в этом случае, да?
If you want to do, you can go up like this, or do, or this, and what about the diastasis? Katuri was this получается. Diastasis. Diastasis. And now, this diastasis.
Значит, использование трансплантата необходимости нет. Этот диастаз спокойно срастается в течение 45-50 дней.
45. No. You don't need to go any bone grafting here, bone transplant here. You should have to wait for 45 days. By this time, it will heal.
It's a cancellous bone.
Cancellous bone, yes. Adduction, medial rotation, medialization. Translation, rotation, internal rotation. Почему это поставили? Фиксатор. Временный.
Можем использовать постоянно, иначе они будут вызывать артроз. А так это в течение нескольких
дней. Have you got the point?
Yeah.
Eh? Afraid of doing Elizarov in the acetabulam, don't be afraid. Fix. Давайте. Во. This is not so difficult.
Because I have not seen that.
If you don't see, it will be very difficult. Orthopedic surgeons must go once in a life in Kurgan. This is my advice. Any orthopedic surgeon, because the biology and mechanics capital of orthopedic surgery, it is called the Kurgan.
You know, the Assami India one has given
Two fellowships.
this year.
2 fellowships. No, without fellows, those who are orthopedic surgeon, they must have target for one time in a life that I'll see the orthopedic capital. They are running only for Western countries, for UK, for USA, for Canada. Why not in Russia? If you don't do Elizarov, even then you must go. You are an orthopedic surgeon. Every day I will send you one osteomyelitis patient to you, one big non-union gap, and one deformity congenital. Every day I will send to you. If you are an orthopedic surgeon, you will run away from that if you don't know Elizarov. Total hip, Elizarov surgeon can do, but total hip surgeon cannot do Elizarov surgery. You agree or not? Yeah. Yes. You agree or not? Lots of TKR surgeon, they are writing knee specialist, but they are not doing HTO. But you are Elizarov surgeon, you can do HTO. You can do AHD, articulated hinge distraction, by Elizarov in the knee, osteoarthrosis. You can do tunnelization of the knee and ankle and the hip by doing Elizarov. Tunnelization, microperforation by Elizarov.
Нужно сказать, что если мы делаем там просто остеотомиотазы или что-нибудь такое, то цель использования аппарата – это, во-первых, облегчить транспозицию и наклон впадины, и, во-вторых, разгрузка сустава. Если же мы делаем что-то более экзотическое, типа операция Ганса или Миномия, то в этом случае там внутренняя фиксация, там открытая операция не такая, как здесь. И там аппарат ставится только для того, чтобы разгрузить сустав. Срок аппаратной фиксации будет меньше. Но зато в этом случае, когда мы ставим аппарат для разгрузки сустава, мы можем позволить себе выполнять эти операции в условиях развившегося артроза.
Хорошо. Значит так, и здесь показание какой был? Чего вы такой тройную операцию делали? Дисплазия тазового синдрома.
Ребенка 8 лет.
So, this is the case that Professor Mikhail Pavlovich Toplinki, he is telling, this is the age of the patient of 8 years, hip dysplasia, DDH. You can do this kind of triple osteotomy. After pulling down the head and put it here and change the position of by doing the triple osteotomy. No, this is broken, that's why he's fixing.
No, how will pass?
Eh?
He
No, no, this is broken, that's why it is.
No, but direction.
This, inside. No, 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 this is broken. Broken, that's why it fades.
How to pass? Yeah, body.
This is the position, no, how to pass?
Left side.
Left side. This is broken, that's why this moving. No, he is not cutting this way. This is only for breaking this, falling down. Direction of this. Sympathy from top. No, yes.
Not in real
No, no, he's talking about the hospital. Real life. See, like the lateral side. Lateral side. Here, lateral side from here to like this. Yes, this is being sympathy. If you have another bone here, then you will be able to understand. Нет, который остеотомию сделали, ведь списки поставили, это очень сложно или нет? Он вопрос задает.
Ну, нужно просто уметь ставить аппарат и все.
So, this is very simple. This operation is very simple, he is telling. Only you have some intelligence in your mind and you must know the topography of what acidibulam avoid. Acidibulam?
Giving the pin through the osteotomy site, the sinus pin. Yes, yes.
No, it
How
will be
to avoid so that it does not penetrate into the acidibulam?
how will this will be pin is in between. No, pin only two pins. Not through both.
Only one board. That's why we need.
Because, for example, we make X-ray after surgery and we see that not enough correction. We
Then you can
fix
change.
this some pins for him and make gradual correction.
Он говорит, что этот пин, если вы поставите, здесь будет лучше. Why?
Why? Because
No.
this pin interfere with the.
Oh, this is cancellous bone, one bone only. That one is okay. And after doing the X-ray, you can change this one position if something here.
We are going to have the workshop on pelvic support osteotomy.
Now you're going to do that. Now any question or you have understood everything? Either you have understood nothing or you understood.
Sorry, I have one question, please. About when we reduce the head in the stabulum, we fix 4K wire to fix the stabulum?
Yes, 4K wires for fixation temporarily.
Temporary, yeah. An abduction position, in which degree we put an abduction?
Neutral position, you will be head.
No, not neutral position.
Yeah.
Because in neutral, it's outside. We need to put inside.
Yes.
The stabulum is dysplastic. Here the head, just this. Here the head is like this. We do abduction and make this. The abduction, how much degree of abduction and fixed by K-wire and the stabulum? And after
Neutral
that,
position, normal position, not abduction, not adduction.
normal.
Neutral position of the head of the femur inside the acidibulum. Then fix it with 4 K-wires temporarily. Then you do the osteotomy. After that, you remove the K-wires.
An abduction position or a neutral
And you
position?
can change the position. Medialization. Он спрашивает вот так. В каком положении головки будет здесь?
Перед операцией определяем, насколько нам нужно наклонить голову.
потом центрированная, головка находится в самом оптимальном положении. Это оптимальное положение.
Optimal position of the head in the center of the head.
And the
It
center
must
of the
be.
head. That's mean the degree. I corrected in
You
center.
must abduction,
Yeah, abduction, yes.
flexion, and
Abduction.
rotation. You must check.
Like the DDH position.
Yes.
This one is abduction,
Yes.
slightly flexion.
Yes,
Fix it, and
abduction,
after that, correct.
rotation.
Okay. Okay, thank you so much.
Yes, and adduction. Okay. Now Agarwal, Agarwal is going to demonstrate the PSO, pelvic support osteotomy. Okay? I'm going. Thank you.
Hello. Hello. We are going to demonstrate you the pelvic support osteotomy. The bones are there at your table. You can do that. You how you will perform the pelvic support osteotomy. So here first of all we will do the first osteotomy, then second osteotomy. Okay. Okay. First of all, in the model we are showing we are adducting the femur bone so it touches the ACL bone. Now we will apply the arch there. For example, in this case there is 35 degree of abduction is needed. So the main thing is that your arch should be like this, so that it should have the 35 degree of the abduction to be covered with that. We will do that transverse arch there. This will be neutral, perpendicular to the body of the 90 degree, so that after abduction, this will be normal. So now we are going to put the arch. So this arch and this bone is making 35 degree of the angle there. या इसका 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 डालिए और ये है 35 डिग्री है ना, ये इधर जा रहा है, ये बोन है, ये ना ये बोन तो अटैक कर दिया ना आपने, तो 35 डिग्री एंगल आर्च से बना रहा है. क्या होता है लाइक रंजो दी. हेलो, हाँ ठीक है. Actually, we want the 35 degree of the abduction. So, yeah, this after the osteotomy. So, we have made the bone adduction by adduction. So, the adduction is 35 degree. Okay. So, this bone. This bone is 35 degree adducted. So our arch should be perpendicular to the here. So this after the osteotomy, it will make the 35 degree of the abduction. No. ऐसे दें क्या गलत? लगाइए लगाइए। लगाओ नट से लगा दो। बड़ा नट दो यार, बड़ा बोल दो। अनुभव लगवा पटक नट डाल दिए। सामने से कैमरा उधर से ले लो, कहाँ गया? सही है। यहाँ से कीजिए। थोड़ा और इधर जाना था क्या? थोड़ा और अपडेट होगा। निकाल लीजिए, निकालिए, पिन निकालिए। नहीं, इसको निकाल के अपडेट। ये थोड़ा ऐसे आएगा। नहीं आएगा। पिन निकालो, पिन इधर इसको निकाल लो। निकालने से पहले दूसरा डाल दीजिए। हम कर रहे हैं ज़्यादा। अब सही है। ड्रिल करना पड़ेगा, लूज पड़ा है। दूसरा वाला देखो, ये ले लो। ये चली जाएगी। ड्रिल करना पड़ेगा। क्या लगा रहे हैं? ये हो जाएगा। पकड़िए, सेंटर में नहीं है। ये चलिए। तो बस हो गया। और हो गया। अच्छा, चलिए। Rencho. Bolt nut. So now we have made the angle of the arch. इधर आ गया यार, ये कर दें. चलिए. ट्राई करिए. ट्राई कर दीजिए. रिंग दो यार. रिंग देंगे कि हाफ आर्च लगेगी. बड़ा आर्च है. चलो यही लगा दो. हाफ रिंग का इसको यहाँ लगाते हैं, इसको यहाँ लगा दें. और बड़ा नहीं है. कहीं से मांग लो यार. So now we will connect this ring will be perpendicular to the femur. बस चलिए. रेंचो. Yeah. So this arch and this arch is making angle of the 35 degree. Try to range. एक इंच और दे दो यार. ज़्यादा पीछे चला गया और ऊपर नहीं गया, ज़्यादा पीछे चला गया ना, पैरेलल ही कर दी, निकाल ली। करीब करीब इसके पैरेलल करना है। ये हो गया, चलिए यहाँ डाल दें। इसको किस में दिया था? 1 2 3, नहीं यही दीजिए। So we are making the second arch perpendicular to the bone, so that after the osteotomy it will make the angle of 35 degree. चलिए इसको ये टाइट कर रहे यार, अनूप तुम आ जाएगा। इसमें किसमें दिया है? इसमें इसमें यहाँ पहले, और रेंचो दीजिए, इधर इधर इधर। यहाँ लगा, इधर नहीं यार, यहाँ इधर लगेगा। राइट, छोटा है यार, ये लगेगा। बड़ा नट दो यार, बड़ा दे यार। उठा टाइट कर दीजिए, रेंच दीजिए। पिन सही है। खोल दो यार, नहीं वो नीचे है, सेकंड कैसे करेंगे यार? इसमें तो हो नहीं पाएगा यार, सीधा कर दें। कैसे सेकंड हो गया? लाइए, तो कैसे हो गया यार? बाद में सीधा कर दिया।
ये तो ऑलरेडी वायरस हो रहा, ये तो वैसे ही वायरस हो रहा जो आप करना वाले हैं।
इसको तो अभी कर सकते। So I am going to show you the
first osteotomy, how it comes into the abduction? Lawyer. Yeah. So we are going to show the first osteotomy. Yeah. Yeah. हाँ यही होगा. नहीं ठीक है. कट गया. So, you know, when you are connected both arches, it makes an angle of the 35 degree. Connect करिए. थ्रेड रॉड लगाइए. थ्रेड रॉड दो यार. ऑब्लिक जरूरत नहीं. थ्रेड रॉड कनेक्ट करो यार. चलो. इधर दे दो. यहीं तो देना पड़ेगा. नहीं यहाँ दे. यहाँ जरूरत नहीं. यहाँ नहीं. यहाँ ही नहीं लगेगा. जोड़िए इसको. इसमें कौन सा है ये? नहीं इंच की जरूरत नहीं है. लगाइए. कनेक्ट करिए. कनेक्ट कर दीजिए. इसको इधर लाया. तो इसको थोड़ा सा पास ले आओ. इसको थोड़ा लूज कर दो. ये नहीं इसको लूज कर दो. अंदर कर देना. इसको अंदर कर दीजिए. इसको ऐसे पकड़ लीजिए. बस. अब करिए ट्राई. नहीं यहीं रहेगा. अब्डक्शन में या यहाँ 2 होल लगेगा. होल लगेगा. ये ढीला थोड़ा अंदर कर दें. ड्रिल मशीन दो. ढीला है यार ये. चलिए. नहीं ठीक है. वो लगा वो ठीक है. इसमें कैसे आएगा यार? कैसे लगेगा यार? रेंचो लगा यार. ये इधर 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 आ जाओ। ये आप लगाओ यार, अनूप आओ यार जल्दी से, अनूप तुम आ जाओ जल्दी से लगा दो। दे दिए, ये लोग रात दिन यही करते हैं। सही, तुम मत लगाओ जल्दी, आ जाए, आप छोड़ दो, लगा लेगा। बस लगा दो, लगाओ, हाँ सही है। थोड़ा सा इधर आ जाइए, दिखाई नहीं कैमरे से, इधर। So now you can see that the abduction at this first house will be 35 degree. Okay, this is clear to all of you. 35-degree abduction. Okay, now we are going to do the second osteotomy. इसको फोकस करो, इसको कैसे करेंगे यार, लगा देते हैं यार, लाई रिंग लाई, वायर दे दीजिए। Actually, this bone is already in varus, so there is some difficulty there. No. वैसे लगा देते हैं, ये टाइट कर बेटा, अरे हो जाएगा, मैं कर रहा हूँ। टाइट करिए, सीधी कर लें, ऑस्टियोटॉमी करके सीधी कर लें, वो बेटर रहेगा। वायर 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 लो, सीधी कर लेते हैं। सो क्या हुआ यार, इसका काम क्यों नहीं कर रहा है? चलिए हो गया है, कोई बात। चलिए स्ट्रेट बनना दो, के वायर दे दो, के वायर से फिक्स कर देंगे, सीधा कर दो, चलो होल्ड कर दीजिए, लाओ। अरे के वायर दो यार रिंग के लिए, अरे बड़े के वायर से यार रिंग के, अच्छा इसको फिक्स कर दें, चलो दे, कोई के वायर दे दो। और 10-15 डिग्री, चल एक मिनट, बस पीछे, हाँ, और इसको फिक्स कर दें यार, इधर से सीधा करो यार, थोड़ा सा चलिए एक और दे दीजिए, कट कर दो इसको। एक और दे दो यार।
ये आपका स्टॉल नहीं लगा,
लगा तो है।
खाली पड़ा हुआ।
या ओके, इधर से एक्चुअली डालिए, हो नहीं पा रहा, उधर जा नहीं रहा। नहीं, अब वहाँ चला जाएगा, नहीं जाएगा, इधर से ही जाते।
उधर से ही जाएगा।
चलो
एक और अरे वो खाली स्टेबल करना है इधर डाल दिए, स्टेबल हो जाएगा।
बस बस बस, काट दो काट दो काट दो। So we are going to have the another last ring. Okay, बार दे दो, एक बार दो। तो कनेक्ट कैसे करेंगे, इसमें जोड़ेंगे। इतना बड़ा कैसे है?
पहले कनेक्ट कर दो, तब वायर लगी, पहले रिंग को सेट कनेक्ट कर दो ना उससे।
कनेक्ट कर दीजिए। हिंज चाहिए इसमें, चलो हिंज नहीं है, हिंज दे दो, हिंज लगेगी इधर भी उधर भी। एक अरे कैसे कर दो यार, एक बड़ा थ्रेड रॉड दो यार, ये थ्रेड रॉड चाहिए जो कनेक्ट करेगा। चलेगा चलेगा, ठीक है। हिंज यार यहाँ लगेगी, वहाँ क्यों दे रहा है? थ्रेड रॉड से कनेक्ट करो, यहाँ है नहीं क्या?
आपकी तो काट में होगी ना।
कैसे कनेक्ट करोगे? सही फीमेल चाहिए ना। लाइए, एक और दे दीजिए। चलिए टाइट,
आपकी कोई रेट लिस्ट है क्या? रेट लिस्ट है
जस्ट मिनट,
यहाँ कोई नहीं है,
ला
कोई नहीं
है उधर है यार। ये चलिए लगाइए, यहाँ लगा। इसको टाइट कर यार, इसको एक मिनट टाइट करो यार। चलिए, बस उधर कनेक्ट करना ऑब्लिक सपोर्ट से, यही ओके। ये बात तो इसमें रिंग होता तब देता, असल में इसमें रिंग होता ना, वो तो छोड़ दीजिए। नहीं सही है। अरे इसको भी तो फिक्स कर दें, एक के बाद दो, इसको फिक्स कर दें, के बाद दे दो। अरे यार ये फिक्स करना,
दिखाने के लिए है।
पेपर चलिए तो फिक्स हो जाएगा, छोड़ दीजिए, बस हो जाएगा। लाइए रिंग, लाइए, इसको टाइट कर दो, और क्या है, सबको टाइट कर दीजिए। छोड़ देंगे ऐसे, हैं? बस हो गया है, नहीं क्यों, छोड़ देंगे ऐसे, लो घास पे चलो। एक और दे दो, फिक्स करो। वायर डलेगा उधर, वायर टाइट करो जल्दी, टाइट कर दो। एक और वायर दो, निकलो। हाँ बस खत्म हो गया, बता देंगे। So now this is the osteotomy side. We have gone to 35 degree of the abduction, and we have done the second rings. So here we will do the osteotomy, and we will apply the hinges, so that the hinges will support to the connect करो यार, बस हो गया, फिक्स कर दो। So now the whole procedure is finished now. First osteotomy and second osteotomy. जोड़ दो।